6:30, folks. People are still coming in, but I'm going to go ahead and get us started. And I will just start out by thanking you all for participating in this, our fourth in a series of 6 on the color of law. We hope you found the presentations each week and the discussions around persistent racism and segregation in our nation to be meaningful and thought-provoking. Most importantly, we hope it has you thinking about what you can do to be part of God's desire that all God's people live and join together. Yesterday, at a wonderful joint service between Knox Presbyterian and Govans Presbyterian, we recited together the words of Psalm 133. How very good and pleasant it is when kindred live together in unity. Sisters and brothers, now more than ever, we must strive for that unity. Incidentally, in addition to the small group questions for the next week that we've been putting in a few days early, usually by Friday, we're starting to put some good resources and links on the One Book, One Presbytery webpage of the Presbytery website. I encourage you to take a look. My sister in faith and co-conspirator in justice, Sharice Jordan Moore, ruling elder at Knox, delivered the powerful sermon yesterday. I understand there may be some technical difficulties, but they're trying to get that sermon up on the Knox website. Assuming it does get up, we will be linking that to our page as well. It was just a wonderful word of witness, and I would encourage everybody, assuming we're able to get it up, to take a look at that, as well as the other really good stuff that we're putting up there. Sharice is with us again tonight as co-chair of the Presbytery's Dismantling Racism team and as a small group leader. And I'm still Guy Moody, ruling elder at St. John United Church in Columbia and the other co-chair of Dismantling Racism. The 6-week study, as we've said each week, is a collaboration between the Dismantling Racism team and the Presbytery's In the Loop ministry group. That ministry group is convened by Kenny Walker, also a ruling elder at Knox, and Kenny is again with us here tonight as well, who will be working with the small groups, and he'll be leading our litany. As always, our Presbytery Communications Director, Frank Pirelli, will keep things flowing on Zoom, and we truly couldn't do this without Frank. Thank you, Frank. Other leaders with us tonight who have helped pull this study together or who are helping with small group breakouts are in alphabetical order: Ms. Brenda Alston, Ms. Lisa Beecham, Reverend Hal Bennett, Reverend Dorothy Bolton, Mr. Bobby Hall, Mr. Dan McCachran, Reverend Ray Mute, Ms. Susan Moody, Ms. Carol Norris Shortle, Ms. Patsy Noir-Barocha, Ms. Annette Snyder, Ms. Nzinga Snyder, Mr. Kenny Walker, and Mr. Chris Watson. Thank you all for stepping up. I couldn't get this done without you for sure. And I will say, by the way, that we've gotten some really nice, very positive feedback on the way the small groups have been going. So thank you all. And by having this many volunteers, we're able to make them nice small groups to have plenty of conversation. So at this time, I'm going to turn things over to Elder Kenny Walker to lead us in a responsive litany. Kenny.
Thank you, Guy. This is our Dismantling Racism litany. I will see racism with spiritual eyes.
Because that is how God sees me.
I will listen with spirit-filled ears.
Because that is how God hears me.
I will speak words of truth and reconciliation.
Because that is how God speaks to me.
I will do what I can to dismantle racism.
Because that is what God wants for his people.
In this struggle,
I will run and not be weary.
In this struggle,
I will walk and never faint.
We can do all things through Christ
who strengthens us. Amen. Thank you, Kenny. And now,
Guy Moody.
yep, back to me. And at this point, I'm going to say that tonight we're going to deviate a little from the usual format in that the guest presentation will only loosely tie in with chapter 5, or indeed loosely with the book itself. However, the topic racial health disparities and its root causes is very much linked to the de jure segregation we have been reading about for the past month. It is a topic addressed lightly in the book, but of crucial importance if we are going to honestly and openly deal with the evils of racism and segregation. And I can think of no one better to discuss this topic than Dr. Lisa Cooper. Full disclosure now, Dr. Cooper has been my dear friend for well over 30 years. Over those years, we have worshiped together at St. John United, and our sons were bookend babies born at each end of December 13th, 1992. Dr. Cooper put up, yep, she's got the slide up, good. Sorry, I was off screen for a moment. Dr. Cooper is the director of the Johns Hopkins Center for Health Equity and Johns Hopkins Urban Health Institute. She's the James F. Fries Professor of Medicine and Bloomberg Distinguished Professor of Equity in Health and Healthcare. She is also a professor at the Johns Hopkins University School of Medicine, Nursing, and Bloomberg School of Public Health. Those are some of her professional titles. But Dr. Cooper is way more than that. Sorry, my screen is acting up at the moment. Sorry. So trying to, anyway, Dr. Cooper has, in addition to her public credentials, she has also done many writings on the subject. She has appeared many times on television and on radio, and all of this and by way of doing something that I have said to her many times, and I know she feels that it's more than her work, it's her calling, it is in her deed, her ministry. And I could go on and on. There's even more said about her on our webpage, but I know that Dr. Cooper would rather spend this time educating us, so I'm going to turn it over to her, Dr. Lisa Cooper.
Thank you, Guy, and thank you to the Presbytery of Baltimore for inviting me to speak with you this evening. It's just an honor to be with you and to share a part of your journey as you seek to become part of the solution to racial injustices in our country. I just wanted to start out telling you a little bit about what I do at Johns Hopkins, and then before we get into the topic. So Guy mentioned that I lead a Center for Health Equity at Johns Hopkins. So I just wanted to share with you what our mission is. Basically, our mission is to promote equity in health for socially at-risk populations. And we do that through advancing scientific knowledge. So that's through research, through training scholars. We have a lot of educational programs for people all the way from undergraduates to, to people who are professionals. We partner with communities in all of our work. And the reason for that is that we really want to raise public awareness of health inequities, and we want to promote sustainable changes in practice and policy. So we don't want to just be academics that generate papers and go around talking about the problem to each other, but really engaging with communities that are affected by health inequity and trying to make sure that we are really working towards change. So action-oriented research. I also lead another entity at Johns Hopkins called the Johns Hopkins Urban Health Institute. And that entity is not focused on doing research itself, but in facilitating different kinds of partnerships. So what our mission is to advance health and health equity in Baltimore, specifically by facilitating and recognizing collaborations between communities and academics, healthcare delivery systems, the local government, as well as the private sector, to build collective capacity for achieving health equity in Baltimore. We also want to mobilize resources in support of promising strategies to achieve substantial gains in the health and well-being of Baltimore residents. So we do that by matching academics with policymakers who are trying to implement new policies or trying to identify what might be an appropriate policy to address health inequities in Baltimore. We provide grant funding and give out awards recognizing when people are doing a good job of partnering together to solve this problem. And then we hold convening. So our third goal is to advance understanding, dialogue, and trust to create pathways to health, well-being, and social justice in Baltimore. So we just actually had a symposium called Pathways to Health Through Housing on actually it was on April 19th. It seems like it was just the other day, but it was actually a few weeks ago. And this picture was taken of our team there. We had over 200 people from Baltimore, people who were part of the nonprofit sector, as well as the faith community, the business sector, the government, as well as academia and health systems, all gathering together to have conversations around many of the issues that are facing Baltimore right now with regard to housing and health. So I know I don't have that much time, so I want to jump right into the talk now. I want us to focus on the fact that health, as defined by the World Health Organization in 1948, is a full state of well-being that includes physical, mental, social, and emotional factors. It's not just the absence of disease. And that's something that we really need to remember as Americans, because our country tends to spend a lot of money on disease and on fixing illness and less on keeping us healthy. So we really want to focus on what it is that contributes to health in our country, as opposed to what contributes only to disease, right? Be that as it may, we know that health disparities are pervasive in our society. They've been here for a long time. They're long-standing. It's been very difficult to address them. They occur across conditions. You see all these conditions shown on the screen here. Heart disease is at the top, and cancer right below that as the leading causes of death in our country, and also the leading causes of health disparities between Black and white communities. So what you may not know is that up until 2020, we had improvements in our life expectancy, really up until about 2014, actually. So it started to level off and not do so well before the pandemic hit. And so we had shown a lot of improvements in that, but even despite that, we had disparities that persisted. And then what happened in 2020, as you all know, is that we had the COVID-19 pandemic. And what that did was to widen the existing disparities. Actually, disparities have become worse since then. And we've had an overall decline in life expectancy that was pretty dramatic for everyone, but even more dramatic for African Americans and for American Indians in particular. And now we're sort of leveling off. So hopefully we'll be coming back and maybe improving more, but we have not recovered from the pandemic nearly to the extent that other countries have. So I want to give you a specific example of health disparities in the United States. And this is a study that was published recently in the journal JAMA. And basically, it shows you that there's been excess mortality. That is like, if Black individuals in America were to have the same death rate as whites, these, they would have the equal number of deaths, right? But these lines show you how many excess deaths occur as a result of Black Americans having higher death rates from white Americans. So these metrics show that over time, we've seen this disparity that continues. But look at this, the excess mortality went up very sharply in 2019. So we have, if you look at the absolute numbers of this, we have, I'm going to give you the number actually. So we have this plateauing, and then we have this sharp increase, right? And so what we see is that the excess deaths were like in the millions and millions of individuals who died in the Black population, and the number of potential years of life lost. So that means compared to what would have been expected, people lost numerous years of life. So we're talking about 1.6 million excess deaths and more than 80 million excess years of life lost when compared with the white population. And so isn't this incredible? Like, we don't talk about this that much, but really the number of excess deaths is equivalent to the crashing of a 747 aircraft every day for an entire year. And we know that if something like that happened every day, we wouldn't tolerate that, but we do continue to tolerate that in this country. So in order to understand and address health disparities, we really need to understand how they exist. And I'm sorry that this went ahead. They are very complex. And as you can see here, there are a number of factors that interact with one another and that affect people in different social groups differently. And I have race at the top of this slide because in America, race is one of the largest contributors to disparities in health, even though we have other factors that are also shown here. And so I want to show you just kind of a causal chain, because a lot of times people say, well, all these things are interacting, but really it's people just they don't engage in healthy behaviors. They eat poorly and they don't exercise, they smoke, they drink alcohol, they use drugs, and that's why they're unhealthy. So, but we know it's much more complex than that. So I want to show you just the cascade of factors that leads to health disparities. So we start out with the first thing, which is our cultural and social norms. And what I call these is systems of power. We have these kinds of ways of being and treating people and valuing people that have been established in our society for generations, where we value people differently based on what racial or ethnic group they belong to, what sex they are, what social class they are in, whether they are able-bodied or have some disabilities, or whether they have a sexual orientation that is the same as the majority. So we have these circulating beliefs and values that shape the sort of prevailing attitudes and prejudices, really. And those prejudices and beliefs actually influence our institutional power. So we have these beliefs that are, in circulation, and then we have that sort of determines who actually is in power in our institutions. And I call these structural drivers. So how are our institutions governed? Who are on our boards? Who are our CEOs? What are our practices and policies and our regulations and laws? To what extent do they benefit certain groups of people over others based on our norms and our value systems? So we have those that then inform living conditions, because if we have certain laws and practices, and the ones that you all are talking about in the Color of Law book are specifically related to housing and neighborhoods, right? Those kinds of laws determine what the conditions are where people live. If neighborhoods have been determined to be redlined and that they're not an economically viable place for people to invest in and to buy homes in, we know that the physical environment will deteriorate. We know that if we locate toxic plants, we will have air pollution, water pollution. We know there will be a clustering of people who are disadvantaged and experiencing poverty, which will lead to a crime. We know that the economic investment in those areas will be down. We know that as a result, access to services, things like healthcare or even basic social services, or things like getting your trash picked up, for example, having green space to be outside and or sidewalks to walk on and to keep you from getting hit by cars. All those things are going to be influenced by those regulations. And then these are where we live determines what kinds of choices do we have to be healthy, to decide whether or not we're going to smoke or we're going to be able to eat healthy. If there are no fresh food stores in our neighborhoods, we are not going to be able to eat healthy. Or if we can't get there because of the traffic patterns, or we don't have public transportation that will take us to places where we can get healthy options. If we are stressed because of these conditions, we're going to be more liable to rely on things like cigarettes and alcohol or drug use to help us manage that stress, even though we know that that's not a healthy way of doing it. But our choices are not as great, right? We might not be able to even get a good job because we don't have access to the transportation. Our schooling hasn't been as good, so we don't compete effectively for those occupations where we would be paid well enough to be able to afford the things we need to be healthy. So this is like the whole cascade that ends up leading to health disparities, where people experience higher rates of disease, injury, death, and lower rates of wellness when they belong particularly to a marginalized group such as African Americans and other groups in this country. So I always put this up because I want people to understand that it didn't happen accidentally, as Guy said. All these things happened because of this precise pattern, and nobody has for generations interrupted this to a significant extent. So it really is going to require us to interrupt this pathway at multiple points in order to reverse the trends we see. So I'm going to show you a map, which I'm sure you may have seen, but this is a map of Baltimore. And you've probably heard of the work of Dr. Lawrence Brown, who has written a book and coined these neighborhoods in Baltimore, the Black Butterfly and the White L. And that's because if you look on this map, you can see in Baltimore City, if you look at the redlining, the historic redlining, you can see it was very much in that center part of Baltimore, but then where you see, in the lower quartile, it's like in a butterfly pattern, like the wings, right? Those are where the wings are. And if you look at where life expectancy is the lowest, that's in those very pale purple areas, that grayish area. And that is really what we call sort of the black butterfly. That's where the lowest levels of life expectancy are. This is another study showing something similar done at the University of Maryland that used publicly available maps and health data from 54 community statistical areas and that collect health indicators and neighborhood indicators in Baltimore. And what you can see is basically there's a 5-year reduction in life expectancy in the red and yellow zones. Do you see where that is, where it sort of fans out from the center, the red and then the yellow areas? And then the areas that are sort of all the way on the outside, the blues and the greens, are where most white individuals live compared to the other areas that are more predominantly African American. And that is because historically, those are the neighborhoods where there was redlining, right? And so we have, in those same areas, we have higher teen birth rates, we have reduced rates of prenatal care, there are also more liquor stores, there similarly are fewer healthy food options, and all the things we talked about previously. So I want to show you specifically, this is a map that I drew because I was interested in comparing 2 neighborhoods in Baltimore that are 5 miles apart. So one of them is Madison East End, and that's where I see patients at the East Baltimore Medical Center. And the other one is Roland Park, which is where a lot of the Johns Hopkins faculty live. Now, these data are from 2017, so not up to date, but the patterns are similar today, and we're waiting for updated data. But so look at the characteristics of Roland Park. That neighborhood is 82.6% white. This is the average annual income, about $104,000 per year. Unemployment is very low, 2.3%. There's like no homicides in the year 2017. That's wonderful, And the the life expectancy at birth is 83.9 years. Death from heart disease, 13.6 per 10,000. We're going to contrast that to Madison East End in East Baltimore, which is about 90% Black or African American. Look at the household income. It's about a third of the people living in Roland Park. Unemployment is about 10 times higher. You can see the homicide rate is more than 7 times higher. And you can see there's, on this slide, about a 15-year gap in life expectancy between those two neighborhoods. It used to be 20 years. So it's come down to 15, which is better, but I would argue not acceptable. And you can see the death rate from heart disease is 3 to 4 times higher, 3.5 times higher in that neighborhood. And I've seen it. I can tell the people that come in to see me in clinic are Black patients who have heart disease, who have obesity, who have cancer at very young ages. They're in their 30s and their early 40s. And when I'm over at Hopkins Hospital or in Green Spring Station, when I see white patients with heart disease, they're usually in their 60s or 70s. They are not 30 or 40 years old. So it's actually noticeable, pretty noticeable. So now we're going to talk about the specific ways that housing affects health. And so experts have written about this, and what they've come up with is 4 different pathways. So the first one is what they call stability of housing. The second one is the quality and safety of housing. The third is the affordability. And then the final one is neighborhood conditions. So we're going to take each one of these one at a time and talk about, what kinds of effects we've had. So first, we have housing stability. So, when we think about housing stability, a lot of times we think immediately about people who are homeless. And that's true. People who are homeless have unstable housing. But there's a whole spectrum of people who don't have stable housing, all the way from people who have lost their home, or are unable to pay their rent, have been evicted due to a recent event in their life, like either loss of a job or a family member has died who wasn't the major breadwinner, all the way to some major illness that they might have had that have thrown them into financial crisis. So, and then we have people who are simply what they call some of them are young adults, some of them are older, they're couch surfing. So we don't even capture all the people who have housing instability. But basically, research has shown, numerous studies have shown that having this kind of stress about not knowing where you're going to be living from day to day leads to terrible effects on mental health, depression, anxiety, drug use, housing, heart disease, things like that. In contrast, there was a randomized trial done back in 2009, actually, that randomly assigned people to get housing and case management. They took homeless folks and randomly assigned them to get housing and case management versus just to the usual, the way that homeless people are usually treated in our society, where there's not a standard program like that. And they found that the group that was randomly assigned to that case management with established housing had fewer hospital days, emergency department visits, and hospitalizations overall within the following year. For every 100 homeless adults that were offered the intervention, they calculated what would be the benefits over the next year. So they said there would be, for every 100 adults, 49 fewer hospitalizations. So that's like half, right? 270 fewer hospital days and 116 fewer emergency department visits. So we know housing stability is a significant contributor to poor health. The second measure is quality and safety. So when you think about quality and safety, what do you think about? We know substandard housing conditions contribute to a lot of health conditions. For example, if you've got moisture in the house and mold, and you've got pests in the house, this contributes significantly to the rates of childhood asthma and to other conditions such as heart and lung disease. We have lead poisoning, which is a major problem, which irreversibly causes brain and nervous system damage in children, leading to lower intelligence and test performance and reading disabilities. So we have a lot of older homes that have deteriorating paint. That's the primary exposure to lead among children. Children ingest the paint chips. Sometimes they just inhale the lead contaminated dust. And we know that that has led to significant developmental and nervous system problems, as well as cognitive disabilities in our children, our African-American children who live in these neighborhoods. So we know that we can prevent unnecessary suffering and well-being by ensuring that people have access to safe housing. There's actually a study that was done recently in seniors, where seniors were randomly assigned to basically their usual health care or to have a handyman work with them in addition to someone who would be like a nurse who would come out to check in on them. And they really found out that a lot of older people needed someone to repair their homes because so many of their illnesses were related to the deteriorating conditions in their homes and to safety issues where they were falling because they didn't have the appropriate railing or the bathroom wasn't set up properly. And so they were able to reduce hospitalizations and illnesses dramatically with that program. It's called Capable, and it's now actually covered by Medicare. So that's a success story. So now we're going to talk about affordability. So we know that this is a huge issue, particularly right now with inflation and the costs of housing having gone up so high. And so we know that in Baltimore City, that millions of people actually spend more than 30% of their income on housing. And this financial strain really gets in the way of people having access to healthcare. It also leads to cycles of poverty and inequity. So there's a very seminal study done called the Moving to Opportunity study, where children in these lower income neighborhoods were actually randomly assigned, these families, to given a housing voucher to move to a different neighborhood versus like staying where they were. And they found that those families where children moved to a new neighborhood over like years that would come up later on performed better in school. They were healthier and had fewer hospitalizations. The outcomes were better, not only for the adults, but also for the children. So we have that. That's affordability, and then neighborhood conditions, of course. And so that actually, the Moving to Opportunity study actually demonstrates the value of moving to a new neighborhood as well. Improved mental and physical health, reduced obesity, and reduced diabetes. And this benefit actually rippled through subsequent generations. How do you like that? So people have more green space. They have places where they can buy healthy food. They can ride their bicycles. They don't have a lot of noise at night. They don't get hit by cars when they're crossing the street. So I'm going to just pivot and then we can wrap up because I feel like I'm going a little longer maybe than I should, but maybe I'm almost there. So I wanted to share with you what Baltimore City has found in its recent community health needs assessment that it does in partnership with the local hospitals. What they do is they survey Baltimore City residents to try to identify the key health needs and barriers to health through systematic data collection from a variety of different neighborhoods around the city. This occurs every 3 to 5 years. It's a collaborative process between the city and the hospitals in the area, and it engages diverse voices. So this year, what they did was they surveyed over 2,000 residents, most of whom were women, about half were Black or African-American, about 18% Hispanic. 38% were over age 60, 33% 40 to 59, and about a third were 18 to 39. So a diverse age range and race and gender. And these are the top needs that were identified by these 2,000 Baltimore City residents. 44% said addiction or substance use was a major concern and need to be addressed. And then similarly, 43% said either diabetes or high blood pressure. And then not too far below that was mental health. And then slightly lower was overweight, obesity, and chronic pain. So, you know, the city residents are identifying the same things that we're seeing in the data. But we really, one of the reasons for doing this is so that the health department can plan with the hospitals which specific programs they want to focus on, because they want to focus on things where people really have identified a need, specific need. So here are some of the social concerns that people raised. Can't afford healthy food, gun violence, no access to health insurance, job opportunities, neighborhood safety, and housing problems or homelessness. So these are the top problems. And this year, the city health department worked with a local health coalition, and they really prioritized housing because of problems that they had observed combined with what they heard from city residents. And that's why we had that symposium on April 19th. So now what they're doing is developing a community health improvement plan, and they've engaged a lot of different partners. You can still become involved. If you want to become involved, you can join the local health coalition, Health Improvement Coalition through the Baltimore City Health Department. That group will help to develop and implement strategies for action and establish credibility for the various agencies and organizations across the city, as well as the hospitals. So, you know, our goal is to get from health disparities, where we have these preventable differences in the burden of injury and disease and violence and opportunities to be healthy, to health equity. And that's where every person has a fair opportunity to attain their best health potential. And there are many paths to get to this. These are pathways that I've, you know, pursued over time. I'm going to go back to this. I want to emphasize that you maybe can't do all of it at once, but you could be involved if you're involved in education. Even I should have put on here business. I've been talking to businesses about how to promote health equity in their employees and in their communities. You can be involved in administration, in clinical work. You can get involved in policy, or you can be a community activist and an advocate. You can encourage people to go out and vote, you know, to support candidates that actually have health of everyone as a priority, and people that support equitable policies such as the Affordable Care Act and the expansion of Medicaid and so on and so forth. So I wanted to just put in a quick plug for those of you who want to learn more about this and learn about how you can get involved. I wrote a book in 2021 called Why Are Health Disparities Everyone's Problem? It's available at the Johns Hopkins University Press website. There's a 30% off code that you can use on that website, which is HTWN, the Johns Hopkins University Press website. And I'll leave this, make sure to leave a copy of this with Guy. And you can also get it on Amazon. So, and I'm going to just stop and thank you for your attention and your time.
Thank you, thank you, thank you, thank you so much, Dr. Cooper. It just seems so funny me calling you Dr. Cooper, but you are Dr. Cooper. We have been friends for so long, and it's okay with me that you ran over a little bit. I wish, and we've had people ask us why we don't have time for questions, and I wish we did, but unfortunately, we really feel we want to break up into the small groups. So with that, I am going to actually put the small group questions in the chat where I have just put them. And I will say that I was so taken last week by the musical theme based on the prophet James Brown that some of you, I hope many of you will recognize that we used a musical theme this week with the great prophet Bob Marley. Truly truly was a prophetic man. We're going to break up. I'm not going to spend a lot of time on the ground rules. I think you know them by now. Be respectful, give everybody a chance to speak. We could just raise our hands informally because the groups are going to be small enough. Make yourself visible on screen if possible. If you can't, let us know why. And with that, I'm going to have Frank break us up into groups and remind you that Frank will bring us back at 5 minutes of 8 for a wrap up. So again, thank you, Dr. Lisa Cooper.